Okay, so let me just say a couple of things about Ronnie, okay? Ronnie and I met about 2 years ago in Barcelona, but we had corresponded a couple of times ago, a few times. And and if you don't know who Ronnie is probably the most effective patient advocate that the neuroendocrine uh, world has. He has the most successful blog, the biggest self-made group in Facebook. He has he has. I have no idea how many thousands of subscribers you have for your emails. He has an amazing website, and and he's an incredible teacher. Being a writer, I had no idea that Ronnie was a writer because he comes from the military, and usually the people in the military have, they don't say a lot. But Ronnie knows how to write. I'm clueless. I'm a zero on a scale of one to 10, but Ronnie is a pro. So, Ronnie, the internet is yours.
I think Mike has introduced me. I did meet him in Barcelona 3 years ago, and he still owes me 1 times digestive enzyme tablet, which I had to give him for his breakfast. But there we go. The title is a patient life perspective, hashtag patients included. But Mike wanted me to talk about my own experience and my own way of coping with living with neuroendocrine cancer as a chronic disease. So I've been living with it for 10 years now. I always put this on my, I'm not a doctor or any form of medical professional, practitioner or counsellor. And neither is anything inside this presentation or on any of my websites the same. I am a patient. A couple of years ago, I was accused of not being a patient, and I'm not sure why. This is my patient story. Now, that's a very busy slide because it's been a very busy 10 years. Now, I'm not expecting you to read every single word on there, but let me give you some headlines. I was diagnosed in 2010, almost incidentally, with a grade 2, stage 4 small intestinal NET. Like a lot of SI NETs, I presented on the scan with a mass in the mesentery with multiple liver metastases. But I also had all sorts of weird things going on. There was apparently chains of lymph nodes, which the initial radiologist before my biopsy had associated with being consistent with metastatic adenocarcinoma or lymphoma, which was quite spooky to read. I had an incidental lung nodule, which I'm told is quite common, and one that's found in every 500 CTs. So I guess that's nothing to worry too much about. I also had something strange going on in my retroperitoneal cavity, some sort of fibrosis, which I now know was a desmoplasia caused by the oversecretion of serotonin. Now, we've heard of this in the mesentery and in the heart. But the retroperitoneal cavity is an unusual place, but I did read a paper from Professor Kaplan, which said it's definitely a thing. Following my first octreotide scan, this is in 2010, they found more hotspots in my left armpit and on my collarbone, technical name, supraclavicular fossa. I can hardly say those words. They're very big words they use in by doctors, and no wonder they go to get so much training. Just how to pronounce words is difficult enough. They also found a thyroid lesion which has been growing and is up to 19 millimeters now. That's another story for another day. And they tested chromogramin A and 5-HIAA after my biopsy. Because they then found out what I actually had. And that certainly explained the flushing that I'd been experiencing, which I completely ignored for about 9 months. I've had 3 lots of surgery. I had a primary surgery to take out the primary tumour in my small intestine. I got the classic terminal ileum resection and right hemicolectomy, bunch of lymph nodes, and a third of this 9-hour surgery was to unpick this desmoplasia, which was had actually fused my aorta and IVC together. Were supposed to be free flowing. And that was a spooky thing because not many people get that sort of surgery. And it's still threatening me today. They didn't get it all, we couldn't get it all. I've had a liver resection, keyhole surgery about 5 months after that, same surgeon. And then about another 9 months after that liver surgery, my armpit lymph node became palpable. And so they decided to cut those out. And interestingly, the armpit tumour were tested positive for NET, but my clavicular one tested negative. My surgeon said that I had an unusual disposition of tumour for a small intestinal NET. But I've since found out other people have got the same issue. I went onto lanreotide immediately after my surgery, and I had 128th injection at the beginning of the month, and next week I get 129. I had, after my initial surgery, which was quite a big one, I developed lung blood clots or pulmonary emboli, and I'm still on blood thinners today. And my thyroid growth eventually led to abnormal blood tests, and I now take a thyroxine tablet every day, which has got my bloods back into normal. And then I got my first gallium-68 scan, and that added a rib lesion, which doesn't really affect me. The clavicle nodes still light up despite having 5 removed, and my thyroid lights up despite it's being biopsied negative. And still activity in the retroperitoneal cavity. They think lymph nodes up the edge of my aorta, plus some remnant liver tumours, which were left behind after surgery. So it's been a busy 10 years. But apart from that, I'm fine. But it does feel like that sometimes. I needed to I do a lot of advocating for people. Obviously, most of it is online. And context is really important with NETs. And yesterday, this was one of the first things that Dr. Glasberg said, and then subsequent doctors following her mentioned the heterogeneous word, because you can have a low-grade, low-stage tumor, which is and curative, ranging all the way up to metastatic, poorly differentiated neuroendocrine carcinomas. And so it's a wide range of different tumors. So it's very important when you talk to a patient to establish where they sit in the spectrum. Otherwise, you cannot have a decent question and answer session. So it's a big word, and I don't think I even pronounced it properly, but the easy patient definition, because you see this in every single NET presentation from a doctor, you'll get this word. And the easy answer for a patient is it's comprised of many different types, as I've just described. And I like to expand the heterogeneity. I think I've got the pronunciation correct there, because it's also important when you're advocating for someone and speaking having a conversation online that to know what the grade is. And lately, if someone's grade 3, differentiation becomes really important, because we can now have a well-differentiated grade 3. Not a lot of people know that, including doctors, or they're just not up to date. It's also useful to know people's stage, if they have a syndrome, which one, their existing comorbidities, because we've got to sort out the symptoms. It's very difficult, and their age can play a part as well. Now, most people in my group are in the age group 50s and 60s, and that is actually pretty normal for many cancers. It's in general terms, an old person's disease. And I hope you can't hear the rain that's battering down on my roof at the moment, because I can. And these are, and it's important to sorry, it's important to, sorry, I wanted to emphasize, it's important to note that these things are not mutually exclusive. So you can have a high grade low stage, and you can have a low grade high stage. In fact, low grade high stage is pretty common in the NET world, because many, about 50% of small intestinal nets, for example, present at high stage, low grade. And it isn't the red flag, it is the other way around. So I'm a firm believer, like Mike, in self-advocacy. And the first thing that I say, and many other people in my group say, is it's much better if you can see a specialist. Or what's becoming more popular is, as the disease becomes more prevalent, which is like that, is a doctor who can work in coordination with a specialist. And that's quite common nowadays, certainly in the large countries where distance can be a problem seeing a specialist, although many people do fly. It's really important that you advocate for yourself or get someone who can, because you can miss stuff. It's so easy to miss stuff, and that's not a good outcome. Very important that you work out what your baseline diagnosis is, and then track it. Now, I'm pretty good on computers. I'm pretty good at spreadsheets and stuff like that, so it's easy for me. But it's so important that you can do that, because you can then prompt doctors who may not be noticing things like long-term trends in blood tests over a couple of years, which is why I prompted them about my thyroid. So it's important that you do that. And it's really important to ask questions of a doctor, and never be afraid of appearing foolish, because no question is foolish. People, when they ask a question in my group, they say, sorry to sound silly. And you know what? Some of the questions that are asked when people say that are actually the best questions, because I really want to answer it. And don't be afraid of healthcare professionals. People are quite afraid to speak to a doctor because they may be appearing foolish, but that's absolutely not what a doctor wants. And but be afraid of, if you think the healthcare professional is talking foolish, you know something that that person doesn't. So don't be afraid to speak your mind about that, if only for clarification. And also we now, and Mike has touched on this earlier, that we should be getting quality of life markers, not just tumor markers. You know, it gives you scores, but what you want to know is, how can I improve my quality of life? Or is my quality of life similar to what it was last time that we spoke? Doctors might be the experts in cancer, but you are the expert in how cancer has affected you, and you should value that experience every time you speak to a doctor. Tell them what's going wrong with you. Produce records from the diary, if you've got one, about what's been going wrong and what sequence and what you're not happy with. What is new that you never had before? You know that. The doctor's not going to know unless you tell him or her. And support is there to help you do that. All of those things sound quite difficult, but you've got a lot of support there from within your MDT. You know, the NET, I find the NET nurses are a very good sounding board before you go and see your specialist. And there's plenty of advocates out there. You know, I consider myself to be one. I've got lots of social media support for people. And also it could be the NET, your patient foundation, whichever country that you're in. For example, Mike in Israel. Your peers. So I'm talking about other patients and caregivers. So it's quite important that you can meet up with people. Face-to-face is so much better, but online is becoming quite vogue lately. And you know, even within a group where you're just talking to people by typing, that can be enormously helpful when you've got something that's on your mind. And family and friends, of course, are always going to be there. In fact, many people fill all four of those sorts of advocates there. Some people are healthcare professionals. Some people work for a patient foundation. And some people are also a patient or a caregiver. And of course, I would say that I have probably more caregivers in my group than patients. And because caregivers do really want to find out just as much as a patient so that they can support their patient. And Mike mentioned that the theme behind today was to talk about ways of living with neuroendocrine cancer as a chronic disease. And it's not easy. And you need to change the way that you think about the disease in some ways. I mean, I wrote an article about incurable versus terminal, and I like to think, some people think they're the same thing. I think they're completely different things, and particularly with cancers where people live a long time with, I think they're completely different. I think terminal is a very short-term outlook where incurable doesn't need to be. And so incurable versus chronic disease is probably what we should be looking at. And in the UK, we have something called incurable but treatable, and I think that suits neuroendocrine tumours excellently, and it can be applied to other types of cancer too, and that equals chronic condition. So living with NETs or neuroendocrine cancer as a chronic disease, that strategy needs quality of life markers. And so, you know, people like the word stable, doctors use it, but doctors also use other terms like controlled, which sounds like it's the same as stable. No evidence of disease, partial remission, partial response. And if they're all different forms of stability, but stability just does not mean things in a clinical sense. It also means that you're living okay with the disease and having a good quality of life. But also you need surveillance. Surveillance is key in it. So if you're not being surveillanced in any way at all, and that's not just scans, that's also appointments, it's also nutritional, it's also blood tests, etc., etc. That's absolutely key with people who are living long-term with neuroendocrine cancer. But with chronic diseases, and any chronic disease, not just cancer, there's a tendency of recurrence. There's a problem, we need to fix it, and then we get back to being stable again. And that can go on multiple times and for many years. And I see that day in, day out in my on Facebook. And treatment can be used to control the cancer, help relieve symptoms, and help you live longer. And I like the analogy from one of my intelligent patients in my group. She talks about the computer game called Whack-A-Mole, where you've got lots of holes in the ground and you don't know which one the mole's going to come up. So when the mole comes up through a hole, you whack it with some treatment and it goes away. And that's quite a good analogy for living with neuroendocrine cancer as a chronic disease. But we do need, I emphasize that again, we do need quality of life markers. It's good to hear Mike talking about that earlier, because we need more people to talk about quality of life markers. It's a big, massive, unmet need. But living with neuroendocrine cancer, it's about appetite, and I mean risk appetite. How, you know, nothing is risk-free. If you are totally risk-averse, you will stay in your house and have a horrible quality of life. So you have to be assessing risk all the time. And I think people do this without even thinking. I'm going on holiday, what do I need to think about? And how can I mitigate that risk? And we're talking about injections and treatment and therapy and pills and all sorts, and what if and all that kind of thing. I think people do that without thinking. And so when I say risk appetite, I'm talking about the level of risk that you are prepared to take to access and have a good quality of life before you think it's necessary to reduce the risk. So we're talking about risk tolerance versus risk acceptance. And there's a useful analogy for you. So I want that piece of cheese.
אני רוצה את חתיכת הגבינה הזאת.
I want that piece of cheese. So I know that that's risky, but I'm willing to take some risk. I shall take some precautions, but I'm going to get that cheese, even if it hurts a little bit. So managing risk is really important. And I'm a man who's continually after that cheese. So I'm continually assessing risks and continually taking precautions to make it less painful. But it's also about appetite as well. So this is a plug for Net Dietitian Tara Wyan's presentation that's coming up. Nutrition support and nutrition surveillance is one of the biggest unmet needs for neuroendocrine cancer patients. And we need to invest more, we need more resources. I'm quite lucky. I've got in my MDT, I have a specialist nurse and I have a specialist dietitian, but I'm one of the few lucky ones. We need everybody to have that. And I campaign for that quite hard, as does Tara Wyan and Mike. Living with neuroendocrine cancer as a chronic disease can be tough because there's a lot of worry and stress and fear involved. And that's the same for many, many cancers. Not everything is connected to NETs. I said earlier that most NET patients are in the age group 50s and 60s, and that's a fact. That is a statistical fact. And that is the age when your body starts to break down a bit, your bits fall off, and all sorts of issues that you get just by being old or older. You know, I like the quote from Dr. Eric Liu, who's quite a famous NET specialist, that every NET patient, even regular NET patients get regular diseases, and that's absolutely true. I see this day in and day out in my private group. And I have to produce the correlation versus causation argument quite a lot. You know, I've got an issue in my left hand, it causes me a bit of pain, so I'm a bit of arthritis, but it isn't NET arthritis, it's normal arthritis. And in terms of fear and worry, you need to I find you need to get this into perspective. And this slide is all about perspective. And so the big pink circle is things that I worry about, which is a lot. The smaller white circle is things that actually might happen. And you can actually analyze that down to that size by thinking about all the things that you're worrying about and grading them. But the actual, in analysis, the things that actually do happen are as the small blue dot there. So I think if you can get a handle on that as a perspective, it helps people cope when you've got an issue that's going on in your body and you can't quite explain it. And other things that you worry about as well. So it's necessary to try to conquer the fear that comes with living long term with NETs as a chronic disease. And the first thing is that you have to accept your diagnosis, and people start to worry from day one, and I completely understand that. But the first thing you do is you have to accept the diagnosis, and you then have to think about, you have to get away from the denial and the anger and the why me. You have to accept that diagnosis, sit down and think, how can I get through this? So you have to start looking forward. But going forward may not be smooth. It's going to be bumpy. And you know, I talked about the fear of recurrence and stuff. But it's important about what happens when you get a recurrence, not if and when you get it. And identifying what makes you worry is always good. And there could be 1,000 things, ranging from if you're younger, you know, what my future going to be like? If you've got young kids, who's going to look after them, and all those things, and how am I going to afford to live? All of these things come out, and you need to identify your triggers. People even get worried about having cancerversaries, so an anniversary of a diagnosis. I actually think that they're very positive things. You certainly need to talk about it. There's no point in keeping it all inside, because this doesn't help. You have to talk about it, even if it's only to one person who's a close member of your family or a friend or whatever. You have to talk about it. And people, this leads people to finding social media, the internet, And that can be a real positive. I find that a really positive thing, but I'm quite nifty. I'm quite good at looking on the internet, working out what's good and what's bad and discarding the bad. But some people, it makes people worry more. So you have to really have someone to help you if that's the case. And some people just get so worried about what they find out on the internet that they shouldn't really go on the internet. And I see the same thing inside my support group, where people say, I'm more worried reading people's stories since I've been here. And I tell them to leave the group and come back when they're feeling a bit more confident. And be patient. If you're going to live with a chronic disease, it's a long-term game.
מחלה כרונית זה משחק לטווח ארוך.
Mike's 14, and there's a lot more people. I found a 95-year-old lady who's been living with it for 42 years last week, which is absolutely amazing. It's a long game. So be patient. Things don't happen so quick. And trying to focus on wellness as well as illness. I mean, if you've had treatment and you're fairly stable and you've got minor complaints, then let's start to focus on how well you are, and then get on with living your life and having a good quality, the best quality life that you can, and start to do the things that you were doing before that you enjoyed. And find new things. I found lots of new things since I was diagnosed, and it helps me cope with it mentally as well. And if all of that doesn't work, then you really need to seek a counsellor and get some professional help. I wrote an article about this. It's called 8 Tips for Conquering Fear, and there's some really good professional counselling videos on there. One from the UK and one from the USA, and I advise you to watch those 2 videos. They're really helpful. I get in trouble for this slide. A lot of people don't like it, but more people like it than don't like it, and so I'll keep sharing it. And the reason I wrote that is because someone said to me, do you think of yourself as a sick person? And I said immediately, honestly said, no, I don't. I don't think myself as a sick person. I think I lead a fairly normal life. I know I've got a stage 4 cancer. I've got a good team looking after me, and I get all my tests, and I'm confident that if anything comes up, they're going to look at that and do whatever needs doing in consultation with myself. And in between that, I get on with my life. And so that was a day out with my wife in a nice scenic part of the country, which helps me physically and mentally. And it makes me think that I'm not sick. It makes me think I actually don't have cancer. And so that is a message that I say to people. If you can turn your thinking to that way, I think it's a positive thing. And it's all about perspective, about living with a chronic disease. You can still have a normal life. And I think some of this is like a summary of what I've been talking about from the beginning, is if you learn more about the disease, and that was something that Dr. Glasberg said at the very beginning of her presentation yesterday. NETs is one cancer where you need to know more about the disease, because I find it really helps me cope. And you need to become more active mentally and physically. And I'm not talking about climbing Mount Everest, because you need to keep it within your limits. And you can see that down the bottom in red, know your limits. It doesn't matter how fast you go if you're active. It doesn't matter how fast, how high. It doesn't matter about that. How much you can climb, doesn't matter. The key thing is go forward. That's what I mean by more active. Even if you walk around your garden or yard, whichever terminology you use, that's it. That's what I'm talking about. Be more active. Start a diary. I keep a diary. It doesn't go into the detail. It just goes into what I know my symptoms are. How are they? How am I feeling? Blah, 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 blah. And that helps me when I go to see my doctor, whenever my appointments are. You have to experiment with diet and nutrition, and I'm sure Tara will confirm that later. there's no one size fits all with that. You know, to a certain degree, you know, everybody, with diet and nutrition, it's also about heterogeneity, because everybody's different. And so you find you have to experiment. And that's also where the diary comes in handy as well. I'm still experimenting after 10 years. I just keep tweaking it here and there. That didn't work, so I'll change. I keep changing little things. You have to advocate for yourself. In my group, I get a great deal of pleasure when I see someone who, when they first joined the group, were quite frightened, they were insecure, they were scared. And after a few months, I can see these people now very confidently answering other people's questions and therefore advocating for others. And for me personally, that gives me a great deal of pleasure and helps me cope with my own disease well. Hobbies, if you've got hobbies from before you were diagnosed, keep doing them. If you found new hobbies, absolutely brilliant. Because all of this helps cope, all of this helps with up here, and it helps you live a better quality of life with this disease. And you can add more to that list if you want, but know your limits. Risks are inevitable, so you have to manage those risks. But as I said earlier, if you are completely risk averse, then that's going to affect your quality of life. You have to take some risks. And don't sweat the small stuff. If your blood test is 1 point higher than it was last time, but still in range, don't worry about that. A lot of people do, and I have to tell them it's not a problem. Motivation is difficult. I rely quite heavily on my wife for motivation. Sometimes she says, let's go downtown for a cup of coffee, let's go out for a walk, and I don't feel like doing it, and I try to get out of it, and she insists. Every single time that happens, every single time, I enjoy what I've done with my wife. And so you need to get your scissors out and cut the tea off. You can do it. And if you notice in U, there's a U in neuroendocrine, and there's a can in cancer. You can do it. Now, those of you who studied carcinoid syndrome will know that there's something called the 5 E's. And these are things that you've got to watch out for, because they could cause your syndrome to get worse. But I invented another 5 E's that actually makes me feel better. And actually, I think these are equally as important as the so-called 5 E's of carcinoid syndrome. This was a real story about a day out that my wife insisted we go on. We drove down to the seaside and we climbed up a hill. That's the hill, and that's the view behind me, which I was completely in awe of this view, and it made me feel so much better. I had to wait to catch my breath from going up the hill, but I exercised my body and I exercised my mind, and I excited my curiosity by going further down the hill, and we found some other beautiful things to look at. After we got back to the bottom of that hill, I ate something naughty that I shouldn't really eat. Fortunately, I had an adequate supply of my digestive enzymes, and so I was able to mitigate the risk. I was the mouse with a crash helmet on, and I got that cheese because I really enjoy a United Kingdom seaside fish and chips, and it made me feel better. And at the end of the day, I enjoyed that day. So there's the other 5 E's, which you can read about in my article, The Other 5 E's, spooky enough. And patient stories are really important. It's one way of saying that you want to be included. And patients included is actually a trademarked hashtag. And my site is Patients Included Accredited. And one of the things I had to meet to get that accreditation was that every single thing that is published on my social media sites has to have patient input. Now that's easy for me because I'm a patient and I do it all myself. So, but if other organisations want to get patients included, I can give you the way to do that. But you have to have a patient input on every single thing you publish. Patients are really important. That's my social media. Most of you are probably on there, but if you're not, you can go and take a look, see if you like it. You can get all that detail from Mike later, or from myself. Mike can probably send you my presentation. But my private group is got 5,500 members. We will be on 6,000 shortly. There's 70 plus countries, and I'm absolutely amazed that I've got that many people in my group in the short time since I established it. It never ceases to amaze me. And, you know, the support that people get in there, not just for me, lots of other patients, is absolutely phenomenal. Oh, I've pressed too many buttons. So there was only one slide there, and that was a slide that says thanks to Dr. de Glasberg and Mike for inviting me here to talk. Thank you.